You are ready with the case, sir?
I am Dr. Ajith. We are the team from JIPMER. Yeah, we are ready.
Sir, please, you can come here. They always
Am I audible?
Yeah, you are
Am I
very
audible?
clearly seen and audible. Thank you very much for adjusting your schedules in spite of your examination going on there. I have
Thank
Dr.
you.
Brian Pinto, Dr. Sandeep with us here to moderate. And please go ahead and show your case.
Okay. Excellent. We have a wonderful team. We are transmitting from the new block of the Cath Lab. With me is Dr. Subhash, Dr. Sashinder, and an excellent team of nursing as well as technical staff. So we have two cases to show you. Because of the lack of time, we've actually started and finished the first case. So we will start with the first case. So without wasting time, I'll ask Dr. Sashi to introduce the first case.
Hello.
Hello, am I audible?
Perfect.
Am I audible?
Very good, very well. No problem.
Okay, fine. So this is the case presentation for the first case.
Okay.
Hello. Yes. Yep. Okay. This is the first case. We had a 55-year-old male who was a known case of rheumatic heart disease and severe MS, for which he was operated, and mitral valve replacement was done in April 2016. He presented here with severe heart failure and he was decongested. His surgical history included, the previous slide please, previous slide. He had a mitral valve replacement procedure which was done in April 2017 with a 31 millimeter TTK Chitra mechanical valve. Along with the procedure, he also had left atrial appendage ligation and surgical MACE procedure also. Next slide. On presentation, he had irregular pulse and his pulse rate was 112 and his BP was stable. His apex beat was shifted and his metallic heart sound was well heard, and he had a pansystolic murmur at the apex. And he was having a basal crepitations in the lung fields. He was decongested with diuretics. His ECG showed persistent atrial fibrillation, which indicated failed MACE procedure. We did a 2D echo, which showed severe eccentric mitral regurgitation jet with a dilated left atrium. To characterize the MR, we did a transesophageal echocardiogram with 2D and 3D imaging, which showed severe paravalvular leak medially at 3 o'clock to 4 o'clock position. The measurement size of the defect came as 3.5 mm. This is a preoperative measurement of the defect size using 3D TEE from the LA end. Next slide, please. This is the image. This is a 2D transesophageal echocardiography image showing 4-chamber view, where we can see the left atrium is hugely dilated. And we can see the prosthetic mitral valve, which is moving well. And the interatrial septum is intact without any LA clot or LA clot. Next slide, please. This is the color Doppler image of the same, where we can see there is a small, laterally there is a small intravalvular leak, whereas medially towards the septum we find a severe paravalvular leak, and we can see the defect also. Next slide. This is the defect through which a severe paravalvular leak was occurring. Next slide, please. We measured the defect using 2D TE, which came as 3.5 millimeters. Next slide. So the gradient across the mitral valve was 4 millimeters of mercury, which is within normal. So the valve was mechanically functioning well, except for the paravalvular leak. Next one. The left is the diagrammatic representation of the mitral valve annulus with regard to clock positions, and the right one is the 3D TE image, which is a full volume rendered image showing the mitral valve annulus with the clock positions. The 12 o'clock position, we see the aorta. Press the next slide, please. And we have the defect at the area of between 3 and 4 o'clock positions. Next slide.
This is the greatest advantage of 3D echo.
In the 3D
compared
TE,
to
we are able to
before.
see the aortic
You can see the defect exactly as the surgeon sees.
Yes.
Exactly. Yeah. Yeah.
Definitely.
Yeah,
So we can see the mitral valve, we can see the tricuspid valve, we can see the aorta at 12 o'clock. Yes, go ahead, please.
Yes, and the paravalvular defect is seen at the 3 o'clock to 4 o'clock position. Next slide. Next one. Okay, this is the full volume rendered 3D image, which has been rotated to see the mitral valve and the mitral annulus. And we can see the defect is exactly outside the sewing ring of the mitral prosthetic valve. We can see the aortic root well now. And the defect was between the mitral valve and outside the sewing ring at the 3 o'clock to 4 o'clock position. Next slide, please. This is a 3D TE along with the color Doppler. We can see a large jet, which is the paravalvular leak, and the blue color is the mitral inflow. Yes.
That's a beautiful advantage of 3D TE. You can see it very well, where is the defect and all, clearly. Excellent demonstration. Please go ahead.
Definitely, sir. Yes. Next,
Yeah.
next. Yes, next.
Can we go to the
So
case?
we have
Yeah.
a large mitral paravalvular leak medially located with a small lateral jet, and his prosthetic valve function was normal without any evidence of thrombus, pannus or vegetation. So next slide, please. So we planned transcatheter closure of the mitral, medial mitral paravalvular leak. Back to you, sir.
Okay. Dr. Kumar, yeah.
Yeah, yeah.
Can we have the first fluoro image for the today? Yep. Yeah. So we just did a fluoroscopy to make sure that the valve movement is okay. There is no rocking, there is no dehiscence. So next. This case we already finished, so we are just showing the recorded images. So as we know, this case this patient had a medial paravalve leak. So that means by convention we will try to cross from the LV side and not from the LA side, because as you know, it will be very difficult to cross from the transeptal point of view. And plus this patient had a very large left atrium. So again, chasing a 3 to 3.5 mm hole from a big LA will be very difficult. So before that we did a transeptal puncture. This is a 2 straight wire going into the innominate. Next. So this is a Mullin's dilator. Next. This is a conventional transeptal system. Next. This is a pigtail from the arterial root. It is being positioned in the non-coronary cusp. Next. So this is a transeptal puncture in the LAO view. So pigtail is just for a landmark, because the left atrium was so huge, we don't want to take any chance here. So you can see that the septal puncture being done. I try to be as superior as possible, because of the leak is around 3 to 4 o'clock. So if you're too inferior and posterior, it will be very difficult to navigate through, even if you do an arteriovenous snaring. So, but yeah, so that we did a septal puncture. Next. Oh, there's a confirmation of LA entry. Next. So then we exchanges for an 8 French Cook valve sheath, and this is just the coil where we use it for BMB. This is just to put it. We put it just to stabilize the sheath so that it doesn't come out. From now, this point, we will switch to the arterial side to cross the defect from the LV to LA. This is being done basically with regard to the location of the defect with respect to the clock position. So hence it's a very medially located defect. As I told you, we cross it from the arterial side. Next. Okay, so you can see this is actually a fluoro image. This picture actually shows, yeah.
For you to come close to septal puncture and go through it. That's why he is preferring the retrograde route.
Exactly, exactly. The other option is, yeah.
Right. Go ahead, sir.
Correct. The other option is to go transapical. But here, as you can see, the wire is crossing into LA, but this is actually the lateral portion, and in between we are crossing through the valve. So this is not the correct crossing. So at this time, we will introduce the TE as well to confirm where we closed. Correct. Now, after that, we after trying for about 10 to 15 minutes, we were able to cross the defect, which was confirmed by transesophageal echo as well. So next. Okay, so this is actually the leak. You can see that this is the RAO view, RAO 30. You can see that the medial paravalve leak defect was crossed with a Judkins Wright 3.5 guide catheter with a thermo straight wire. So, and you can see the loop of the wire in the LA. So the LA is very huge here, as we saw in the echo. The venous axis, the venous system is staying intact. That is the Cook the 8 French sheath and the wire. Now from this point, the idea is actually to snare this glide wire from the venous approach. So for that, we introduced a 6 French Judkins guide catheter again through the 8 French sheath, and again we passed the glide wire, thermo wire, to overlap the arterial as well as the venous wire, and then we pass a 20 mm snare to snare it out, okay, and then we created an arteriovenous loop. Next. Next, I request the chairpersons and whoever has any doubt at any point to raise the doubt, be free.
This
Next.
is basically, again, he's trying to make it a AV loop, and we'll go through the venous side of the device. That's what is the steps going on. Okay, we are following you,
Next.
sir. Go ahead.
Okay. Next. So this is the Judkins right coming through the sheath. Next. And then creating an overlap, and then for advancing the snare. Next. So once we snared it, we create an arteriovenous loop, and this is a 8 French Moulins again coming. And as you can see here, we had some difficulty in advancing the sheath across the defect. As you can see, the sheath is buckling down. The sheath is exactly stopping at the valve ring. So that indicates that probably there is a significant tissue which is preventing this sheath advancement, or our sheath is a bit bigger. The repeat measurement of the echocardiography at this point, we actually had a different measurement. It came up to 5.7 millimeter. So it was not 3.5, it was 5.7 millimeter. So at this point, we exchanged. So we exchanged this sheath for a Cook shuttle sheath, which is actually a braided sheath, and we undersized it. So from 8 we came down to 6 French. So then we advanced this 6 French Cook select sheath. Next, Cook shuttle. So this is, you can see that this is over a thermo wire, 035 wire. Nowadays for creating AV loop, we don't change, you can see the sheath crossing in. Yes. We don't change to a stiff wire. We just do it by pulling both the ends of the thermo wire itself. Most of the time it works. Yeah. This is to avoid excessive myocardial stretching and sharing, especially we learned with this our transcatheter VSD closures. Yeah. So you can see that with that pulling and pushing, we could advance the Cook, this is the, Cook's shuttle sheath 6 French, which is a braided one, into the aorta. Now the next challenge is actually to pull back the sheath into the LV, because we want to withdraw the device from the LV, not from the aorta, right? So for that, side by side to this thermo wire, we pass the extra stiff wire, Amblat's extra stiff wire. Next. 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 Okay, so this is the, watch carefully, this is the extra stiff wire coming in. This is a very useful tip to know. So we slowly withdrew the sheath and then push the Amblats into the LV apex.
Okay.
And now we can easily advance the sheath over this. Next. Next. So with this measurement of 5.7 millimeter, we had the option to take either an ADO1 device or an AVP2. These are our devices of choice, ADO1 being the preferred one for us. The second one is actually a vascular plug. With a measurement of 5.7, with a 6F sheath across, we chose to take an AVP, that is AVP2 10 millimeter plug, because we normally double the size of the defect with the AVP, right? Yeah. Next. So now we can see the transesophageal echo also coming.
Devices which have a larger rims, the advantage of this ADO2 and the VSD is rim should not be too big because it will obstruct the valve. So that's why either vascular plug or ADO devices are preferred.
Yeah, so I think that's a very good kind
so
of
in the opening post, yeah, correct. In the opening poster, in the valve poster, we measured the difference between the annulus and the valve opening point to be about 12 millimeter. So that means even if you're taking an ADO1, you should take only 6 sides so that the retention skirt is 12 millimeter. So always remember that taking a larger device is always not an option for a para valve. If you think that the defect is too big, you take 2 small devices rather than going for one big device.
Yeah.
So here you opted for a 10 millimeter AVP2.
It goes to 6 French.
Next.
Kind? Sheath AVP2 goes to 6
It goes through 6 French.
Okay.
Sheath, yeah. 10 millimeter goes through a 6 French sheath.
Okay.
That is another advantage. Yeah. If you are taking an ADO1, probably you need a 7.
Yeah.
Next.
Venus, it shouldn't matter.
So this is the plug being deployed.
Yeah.
So here actually I have kept a safety wire inside. You can see that side by side the device there is a wire into the LV. This is in case I need to put another device or double up the sheath so that the access to LV is always retained.
Yeah.
Otherwise we have to again do the same process again and again. So this is a 10 millimeter plug snugly fitting into the hole. At that time we started looking at the TE. So can you just show the echo pictures please now? Echo. Just take off the fluoro, just show me the echoes. Yeah, okay, this is a pre-procedural, can you just go next? Okay, this is a para-valve leak, next.
The device one you can show.
So this is a confirmation, this is very important.
Yeah.
This is very important to know that echo, you make sure that the wire is through the para-valve, not through the valve. This is very important step. So now in the transesophageal, you can know that you can see that the wire is crossing not through the valve, but through the side of the valve. Next. You can clearly see that now. Next. Yeah. Next, sheath confirmation now. Next. Next, please. This is a live 3D. Next. So this is again by advancing the sheath. Okay, this is a measurement we got now, which is about 5.7 millimeter.
Yeah, that we saw, sir. You can show the device one.
So now this is
Yeah.
now the device. You can see the device there, sitting in there. Okay, can you just show the next fluoro? Next fluoro. Okay. At this point, just once we made sure the device is stable and there is no more leak, we just withdrew the safety wire. Next. And then this is the release of the device. Just pulling back to make sure that the device is stable here. Next. Okay, so that's the release of the device. Next.
Yeah, 3D shows it excellently.
And
so
the device is quite stable. You can use. Yeah, you can. Yeah.
Yeah,
You can see the
saw
3D
it.
as well.
You can see the 3D.
Next. So that's the procedure number 1. I am happy to take any questions.
Now, can you just show? Did you take a picture after deploying the device? Sorry.
Yeah, that's what now you're seeing. This is the
color
LAO
jet.
picture.
If you can.
Yeah, can you just show the last post device release, the 2D T.
Okay. The jet what we were
Are you seeing it
before,
now?
I think it's significantly.
Echo? Yeah, it is not there.
Yeah, no
the
defect. No,
flow is actually trans valve.
Perfect closure, I think. There is no regurgitation now at all.
Yeah.
Excellent demonstration, sir. I think, yeah. We'll go on to your next case
Yeah.
now.
So that is in another lab. By the time I just switch over the mics.
Okay, we'll just
Any
break
questions
for
on this
5
case?
minutes. We'll give you 5 minutes time. Then you can go to the other lab and become ready, sir. Okay.